Jean Moody Williams. I've known her for a very long time, and she is a deputy director of the Center for Clinical Standards and Quality. She helps lead policy activities for the quality improvement programs, the end stage renal disease networks. We know we have 18 networks throughout the country. She oversees survey and certification, quality measurement, and she's really responsible for making sure that quality is good in the Medicare patient population. And today she's going to give us an overview of quality measures. So I'm really excited, Jean, for you to be here today.
Thank you so much, Lori, and thank you for inviting me. I always look forward to these opportunities to come and speak to you all. And this is really a great way to end the weekend. I know you all are meeting throughout the weekend. I'm going to share my screen because I do have some slides I'd like to walk through with you, just to keep me on track, because when I get to talking about this topic, I could just go on forever, and I want to stay focused. So first, it really is, as was noted, and you noted my name should, it sounds like one of an author. And of course, I am an author, and written a couple of books. One is a textbook for healthcare professionals, and another one is a devotional for caregivers. But in all of those books, they talk about they really focus on the voices of patients and families and caregivers, and helping to make decisions about their own care, and to inform clinicians, nurses, doctors, physical therapists, whomever they are, about what it is that matters in their lives. I just got off of a call with a facility that is really giving patient-centered care. And they say they always start their conversations with, rather than asking the patient, what's the matter, they ask, what matters? And that really does give a very different response as the clinician starts to do the work. So I have up here a couple of statistics that you all are probably, most everything I say today, you're probably even more familiar with than I am. But it really, I have a number of responsibilities, as Larry said, in my role as Deputy Center Director for Quality for nearly 40 million plus Medicare beneficiaries. We work with Medicaid, we work with the marketplace, so over 100 million lives. But the lives that for patients with kidney disease may be smaller in number, but so impactful in the work that I dedicate a lot of my time to. We know that there are a number of patients, we see over 700,000 with end-stage renal disease. There's more than 60,000 Medicare patients waiting for kidney transplants, an area that a number that we want to get down. And I'll talk a little bit more about that as we go through. We know that the population, unfortunately, has to consume a number of Medicare dollars because of the resources that are needed. And we want to make sure that those dollars are spent going to what you want, the kind of care that you want, so that there are resources available, and working toward kidney transplant. So those are the numbers. But what I also like to focus on is what's behind the numbers. And for those who may know me and who have attended our quality conference that we have every year, this past year was virtual, but nonetheless, and hopefully as long as I'm there, I can hold true to this. I never start one of our quality conferences, and we have over 5,000 people that attend, without starting the conference on day one at the plenary session with the voices of patients and families. And this year, although virtual, was no different. And in fact, it was patients with end-stage renal disease that were with me on our panel discussion to start our quality conference this year. This is actually from, I would say, about 5 years ago, where we have, we always have patients and families at our conference, and they have integrated tracks where they get to talk to clinicians and everyone. And then they also like to have their own track where they can get together, support one another, have dinner. And so this was done at one of their own tracks, where we had an artist in the room and just taking notes about what their thoughts and desires were. And I keep this with me all the time, either on a PowerPoint or on my wall or somewhere, to take me back to what it is that's important. And it says a lot on here, but some of the things it says is, I work at staying alive. Educate, encourage, and empower. That's what they do as they advocate. They remind me to listen to me. I know my body. And again, this is about 5 years ago, I think. And it was really a big push for home dialysis and telehealth. They said, we want more of that. We do have, 5 years coming up, we have more, but not to the level likely that would be the desire. And I'm ready to learn from professionals. Are they ready to learn from me? And that's the one I really take to heart as I'm writing policy decisions. So I want to talk a little bit about what we're doing at the administration as it relates to quality and some of the activities and how we want to hear your voice as we go about doing our work. And of course, one of the priorities that we have right now is the path out of the pandemic. There's probably not many families in America that hasn't been impacted one way or another, directly or indirectly, by this pandemic, including my family. And so we need to, and we're doing better with this. Things are getting better, but many of the problems that existed obviously before the pandemic were just exacerbated during, and we need to take this moment to learn from that. When we look at the hospitalizations, you can see these are hospitalizations for people that had a diagnosis of COVID-19 and other conditions that went along with that. And as we know, many, particularly Medicare beneficiaries, have multiple of these conditions, not just one. And we see kidney disease is at the top, and anemia and other things that are common. So it speaks to the fact that there's still work to do. Now, we are beginning to see improvements, particularly in pockets across the country. And much of that is related to the vaccine that has become available, and with the primary dose, and for those that are immunocompromised, for the booster. And we track this, and you can see we looking at this latest data that's available from the CDC. We have reporting from 7,163 facilities, and the percent of patients that are fully vaccinated with the primary dose, at least, is up to 71.5%. And those that are partially vaccinated, meaning at least a single dose, if it's a 2-dose vaccine, at 4.1. So about 75% of the patients now are vaccinated. And we want to encourage that continue to go up. What we're finding is, and this is true in nursing homes as well, where I think it's 84.5% of nursing home residents are vaccinated. That is not necessarily the case for the healthcare workers that are taking care of the patients. And so the president announced about a couple of weeks ago that healthcare workers should also be vaccinated so that they can protect themselves and protect their families, but protect the patients that they're caring for. In the nursing home setting in particular, I think it is somewhere in the area of 60%, almost 60% are vaccinated. And we're working to get numbers from other settings as well. But this will be the push over the next several weeks. We are in the process of writing the regulation. We are getting comments from many sources, including patients, saying varying opinions, as you can well imagine. But many patients are saying that they want to see their healthcare workers vaccinated, particularly if they're coming into their home to do training on home dialysis or home health or other kinds of things. So that's one of the things that we are spending quite a bit of time with. The other thing, as you'll notice, is we're looking at the race and ethnicity of those that were most impacted during this pandemic. And it's pretty easy just to look at those bars to see the impact. There was a book that was written by the Institute of Medicine many years ago called Unequal Treatment. And it really outlined how the care in this country is not always equitable. And there has been little progress really since the publication of that book. And people who are Black, African Americans, Hispanic, Latino, or American Indian, Alaskan Native were about 3 times as likely to be hospitalized after contracting COVID-19 and about twice as likely to die from the illness. These unequal outcomes were compounded by longstanding disparities in life expectancy, morbidity, and access to care. And these are things that we cannot continue to find acceptable. The ESRD population is very diverse. And so this is a matter that is really pertinent for the population as we look at kidney health. What the thing that we're running on, the area that we are really working toward is that every person has the opportunity to attain his or her full health potential. And no one is disadvantaged from achieving this potential because of a social position or other socially determined circumstances. So one of the things that was also just announced about now, I guess almost a month and a half ago, was the establishment of the Office of Climate Change and Health Equity. And this was in response to an executive order. This is the first time in HHS that we've had this kind of national level office at the level of the secretary. And the office is really to look at those most vulnerable in communities due to health conditions, identifying communities with exposure to disasters such as drought, wildfire, floods that are becoming increasingly prevalent in our communities. And we know the impact of that, particularly for those that are on dialysis, and how that interruption comes in not being able to get to the dialysis facility that they're so dependent on. We have a kidney community emergency response. It's called CASER. And if you haven't heard of CASER or if you haven't worked with them, that's a good thing because it means you probably haven't had the need to. But I can guarantee there are probably some on this call that have had a need to relocate to another center to get care, or to a loved one or a family member or someone that you're supporting if you're not on dialysis has had to relocate to find it because of a flood or because of a fire. And so this group helps with that. But they have a number of resources that are available to talk about what to do in the case of an emergency. But with this Office of Climate Control is really to look further upstream before the emergency happens. How can we control things such as the greenhouse gases, many of which come from hospitals? If you think about anesthesia, when you give it, it gives off a gas, and there are other things that happen in healthcare settings that really contribute to climate change. So it looks further upstream to see what can we do so that we don't have to be always in an emergency response mode, but more of a prevention mode. So I encourage you, if you haven't, to take a look at this CASER.org site. It's got lots of resources for patients and families and caregivers to prepare for emergency situations while we work to try and decrease the number of times that we are responding to emergencies. Now, this that I'm showing you right now comes from our new administrator. I guess she's not new anymore. She's been there not quite 9 months, but maybe about 6 months. But it usually takes that long from a new administration when you get a new administrator in to come in, learn the agency, learn what the programs are, and then to set a vision of, okay, here's what I want to accomplish during my tenure in this particular office. And so probably about a month ago at most, she publicly released, and that's Chiquita Brooks-LaSure, who is our administrator, publicly released this vision that, of course, we want to serve as a trusted partner, steward, and we want to be dedicated to the advancing of health equity, expanding coverage, and improving health outcomes. So there are 6 pillars for which she has charged us to ensure that we're working on to make healthcare better in this country, health and healthcare better in this country. The pillars, the first one addresses equity and reducing health disparities, and that is just a part of the way that we work. The second one is really expanding coverage to ensure that those that need coverage and care have access to it. And for example, the open enrollment period has been extended this year. It will go until January 15th. So that's one of many things that are more tools are available to help patients and families enroll. Also partnering, and this is partnering with the community. I know this conference and what I'm talking about is listening to patients and hearing their voices. And that's really important to our administrator. And she's held several listening sessions with various partners. I've always held listening sessions, but even today, as I finish, if you want to email me your thoughts, send me anything, I'm happy, more than happy to receive your concerns, your thoughts, what's working well, what's not. I'm always available. Lori knows that, to listen. Also, driving innovation, and it's in all areas. And I'm going to talk a little bit more about innovation in kidney health, which sometimes, the innovation is not fast enough. We all want it to move a little faster in kidney health. So I'll talk about that. But also protecting our programs for future generations, being responsible stewards, making sure, I talked a little bit earlier about that we're spending the resources wisely so that the generations that come after us can, in fact, still be able to get healthcare in this country, that we're not wasting it on unnecessary procedures or things that aren't really improving the healthcare. And then fostering, and this one is more inward focused, making sure that the workplace that we work in is excellent and that we are aware of the needs of our workforce. So that's what we're working on. One of the goals, and remember I talked about stakeholder and innovation and all of that, is looking at our transplant system. So because we know that we would prefer that if candidates are eligible and suitable, for a transplant, that they be able to receive them, and that it be a seamless system, and that they not have to be on a waiting list for very long. So that is a future vision. And one of the things that we hear is that there's a need for better coordination at the federal level to ensure that the system is working well. We did release a rule the end of last year was final proposed rule, but it was finalized this year, really on the organ procurement organization. And in that, we had some new outcome measures where we're measuring the number of organs that are available for transplantation, but then also the number that are actually transplanted. So those are the quality measures that we are looking at in the conditions of participation. But what we heard from the community, including the patient community, and obviously we knew this, is that the organ procurement organization is just one piece of the system, and that we really needed to look at the whole system, how it impacts the donor families, the receiving families, the OPOs, the transplant surgeons and transplant centers, the networks, the dialysis facility, the advocates, all of that needs to be considered. So we are doing that. We have started a cross-department work group with both CMS and HRSA and others that work in transplant to ensure that we can work to get more organs available for transplantation for those that need them. We started with just kind of a flow diagram. I'm not going to go through this, but really tracking all the things that happen from the time that an organ becomes available to the time that it's actually transplanted, and where things are breaking down along the way, so that we can address them and try to make them whole for patients and families. As we talked about ESRD networks, and you're likely familiar with them, they have a focus on quality improvement activities, patient engagement and education. They have patient advisory councils, also grievances if there are problems that you feel should be addressed. There's a system that's available that can intake any questions or concerns that you have, and then those are investigated by the ESRD networks to determine where the problems might be. And emergency management, which I just talked about a little bit earlier. So those are the areas in which the ESRD networks work. And they are always looking for the patients to help them achieve the goals of the networks. So yet another place where your voice does make a difference. We have them all over the country. There are 18 of them. You can come to our website to find out the one that's servicing your area if you're not already involved. And they are more than happy to provide resources even on their resource page. They have a number of things for patients and families that were, most importantly, developed by patients and family. And so that's one of the resources. So what's our vision? We want to, of course, align with the administration's priorities that I just mentioned, but more important, just as important, I shouldn't say more important, just as important, the customer feedback from the beneficiaries as we implement policy. Rapid cycle improvement. So if we find a problem, there's a grievance, and we see a pattern of care at a particular facility or system, that we study it, but that we don't study it for 6 years, that we go in, we see what the problem is, and we try and offer solutions. Transparency, so that people can understand what is going on in ESRD, getting their questions answered, and holding the networks accountable. They have performance metrics that they must meet, and it's really our job to make sure that they are achieving what we expect them to achieve for patients and for families. So again, we expect them to be data-driven. So I talked about data early on. So they look at the data, they monitor how many people are on the wait list, how many people were added, how many people are actually receiving kidney transplants, and a lot of their performance metrics center around these numbers so that there's expectation of action. And again, I mentioned resources. You can go to, this is www.esrdncc.org. And here you can find where all the networks are, as well as the CMS website and the tools there. There's an affinity group, a learning in action network of patients. And these are materials that have been developed. So you can help develop these materials as well. And also some of the charge, we've already mentioned health equity, but that's specifically in the contract, as well as behavioral health priorities. So those are things that are in as well. So I want to talk a little bit about the quality improvement program. So this is required by law that it's called a pay for performance program. And it really looks by statute, by law, at the quality of care that dialysis facilities are providing to patients. And so the authority comes from what's called MIPS, the Medicare Improvement for Patients Act, and then later Protecting Access to Care, which is called PAMA. And what the law says is that it requires CMS to monitor and to get data from facilities on anemia management, to the extent feasible, patient satisfaction, iron management, bone and mineral metabolism, and vascular access. It also asks us to have outcome measures. So not only are people doing the right things, but is it making a difference? So when we talk about outcome measures, we're really saying, does it make a difference? Is it improving anything? And to consult with the law says to consult with stakeholders as we are designing these particular measures. Now, and the measures are broken into categories, and then the facilities get points for how they're meeting each of these particular categories. So, for example, there's a clinical care domain in which 40% of the 100 points, they get 100 points, 40% of those points come from the kind of clinical care that's being provided. And we look at vascular access, hypercalcemia, the filtration. So that's 40%. And then 30% is care coordination. Are patients being readmitted to the hospital? And that's looking to see where readmission could have been prevented or hospitalization could have been prevented. Depression screening, very important. And how many patients are on the wait list? Also, and both things, they should be put on a wait list if that's their desire. But then how long are they staying on it? So it's two-pronged. Then the patient family of care and family engagement. What are the patients saying about the care that they're receiving? And then safety, looking at infections and medication reconciliation. So all of that comes together, and facilities get points for that. And if they do not do well, there's a 2% payment reduction in their payments. So it's graduated at 0.5, then 1%, 1.5, and 2%. So you can see that 73, almost 74% of facilities get no reduction, which means they've met the quality measures, and then the remainder gets some portion of that reduced. So all facilities, unless they have very low numbers, really are required to participate in this program. All of it required to participate, but we may not publicly post if it's very low numbers. but they're also required to put their score, post it in an area where patients can see in both English and in Spanish. And as you go into the facility, you should be able to find what that score is. And if patients have questions about the facility, they should also be able to ask about that. I'm also looking at the chat, and there are resources in there, and I see peer mentors. The Renal Support Network is putting in how you can also get information on this. So please pay attention to that as we move forward. So then this information is available on our Compare site. And I'm speaking right now, highlighting the dialysis facility. Based on those quality measures, you can go in and compare different facilities. But I also want to call your attention to the other resources. You can look up your clinicians, hospitals, nursing homes, home health, all the kinds of services that are available. You can do a comparison. Here's what it looks like if you've never been on the site. These are two, you just put in your zip code or whatever measure. You can put in a exact name if you're looking for a particular facility to see how did they do on the quality score. What are the patients saying about the facility? And then it translates into stars. So there's a star rating. You have a 3-star rating, you have a 5-star rating, and you can look to see what that means as you look at the dialysis facilities. Now, if you remember, I said that this is all put in based on law, and every year we do rulemaking. So it's called the End-Stage Renal Disease Prospective Payment System Rule. And when we do rules, you, as the public, you are encouraged and invited to solicit comments. Now, not many people want to read a 2,000-page regulation that CMS puts out, and I understand that. So I encourage you maybe to work with organizations, advocacy organizations that do that. That's what they do. They read our regs and they say, okay, here are the things that you might want to comment on when CMS puts out a rule. And here's something that's going to impact the kind of care that you get. Your voice, let me tell you, your voice makes a difference. We hear from everybody else who have loud voices. And if we can hear from patients as well, it helps us to know how to balance things. But in this past rule, we did a proposed rule. We haven't finalized it yet. We asked about vaccination measures. Should we have quality measures about vaccination? How can we help to close the equity gap? What about digital quality measures? How can we use data more effectively? So that's in that rule. And also the other thing I wanted to talk a little bit about is what's coming down the pike for the future. And I was privileged to be one of the judges for a Kidney X project, which is ongoing. But Kidney X is a Kidney Innovation Accelerator. It's a public-private partnership between the Department of Health and Human Services and the American Society of Nephrology, really looking to see how can we accelerate innovation in kidney health. There hasn't been really what we would say groundbreaking innovation in kidney health in a number of years. And so we want to incentivize. We have Kidney X is really a prize, a challenge prize to innovators that if you can come up with good ideas, then there's the ability for us to help support you in doing that. Things that help in prevention and diagnosis and treatment. And I served on a panel with patient representative. So it's not just, I was there as a nurse and as from CMS, but there were scientists and researchers and patients. It's really a diverse panel looking at how can you come up with, they were looking at wearable kidneys or that be functional and could be patient, what was the patient impact and how it could be developed in a rapid manner. And there were some wonderful ideas that are coming to the forefront. So we continue to encourage that as we, little microchips that can change how dialysis works so that they're not huge machines that are available. So I wanted to kind of end, I tuned in at when I tuned in at the beginning, it was just at the place where I wanted to end. And that was just to encourage you as we talk about giving your voice and coming to quality conferences, commenting on our regulations, being an advocate, working in with the ESRD networks and having your voice heard. All of that is taking place while you're trying to take care of yourselves. And so I want to encourage you to continue to take care of yourselves. And I heard Cher talking about yoga and stretching and creative. And we all need to take a moment to do those kinds of things. But knowing all the things that you're trying to manage, really, it's important. And seeking peer support and through our ESRD networks and other networks that are available are very important. Just as this meeting that you're having today, I applaud you for this because you can support each other. Take advantages of resources for depression. We understand that that is in the population in general and certainly in the kidney health population. Ask questions. We encourage you to ask questions that are concerning you. I always ask my staff, what's keeping you up at night? And then there are many questions that come up, but asking them to get answers, injecting hope with things that bring you joy. What brings you joy, and how can you do more of it? And participating as advocates for better kidney health. I believe sometimes we feel better when we're doing things for others, and I know that certainly helps me feel better. So I encourage you to do that. But another thing I always like to think about too are the families and the caregivers that help support you, or maybe their caregivers and families even participating. There are some resources available, particularly through Medicaid, where there may be respite care for caregivers, or certain states allow for certain payments to go to caregivers. And that does, Medicaid is state-based, so it does vary from state to state. There's some opportunities through Medicare as well. Caregivers, beneficiaries with end-stage renal disease can receive dialysis training while as well. And some of the home health benefits support caregivers and Medicare Advantage plans. And I know that's a kind of new in the mix, but many Medicare Advantage plans have supplemental benefits that can support caregivers. So that's also an important thing to mention. So there are any number of areas that your voice will make a difference. And I applaud you for all you're doing. And I want to thank you again for this opportunity to meet with you.
Thank you, Jean. That was really wonderful. I know that it's a lot of work. You have a big scope under your job platform, and I know you've been doing this a long time. So I thank you for your dedication. I have a couple questions. Robin Sales has a question. Addressing doctors' workload is a major issue. Typically, I see a doctor on the computer trying to meet requirements and trying to maintain eye contact at the same time, or they save the computer work for after hours and are swamped either way. This impacts patient care doctor burnout. So I guess the question is about, with all the reporting required, how do you balance that?
Yeah, no, absolutely, because we want patients to be able to have that relationship with their clinicians, and we want clinicians taking care of their patients, not doing paperwork. Some paperwork is necessary because we know I am a registered nurse, so and most of my colleagues are healthcare professionals. Healthcare professionals do not go into healthcare to harm patients. We go into healthcare to help. But things are things do happen, and things do need to be monitored, and there are oversight requirements. And we do know where there are incidents every day where unsafe practices occur. So we do try to find a balance. Particularly when I was telling another audience, I was the director of quality improvement for a long time at CMS, and I work with quality improvement organizations. And there, we look at always how things are improving and where's the data going, and we look at the whole, and it looks really good. And then as I became deputy director, I also became director over the survey and oversight, where you go in and you do the inspections, and I would get these reports about patient harm coming through. And so I didn't really have the best picture until I went into this role. But one of the things we are doing, just to answer your question directly, and we started this really a couple of years ago, was looking exactly where's the burden and what can we cut out? What measures can we streamline? What's the most important thing that needs to be done? And if it's not important, how do we get rid of it? And we really, as you saw that journey where we were tracking through for transplants, we did that for patient and for physician and clinicians burden, and really work to streamline a lot of the measures. Now we hope, and when I talked about digital measures, and I didn't really talk about it, but you may have seen it on my slide, the idea would be once we really get electronic health records doing what they should be doing and that they're easy to use, then the data that's needed for quality measure, for patient coordination of care should be easier. You can just go in and get it. You don't have extra forms to fill out. And that's what we're trying to work toward. And it's happened in other countries. It happened here.
I know, it's interesting because I have a couple different portals, and it's a little bit crazy at times because, if there could be just one portal that everything was connected. And I know that I think it's Taiwan that has that system where, just let the credit card business take over the medical records business, and they'll get everything in one place.
Right.
And they have a little card, and all of, their information is in that card. And I think it's exciting. I have a couple questions. My first question is, and it was a big focus of the proposed rule. For those of you, RSN has an ambassador group, and we do comment and we help as much as we know, because as she said, it's 2,000 pages, and my limit's about 20. So I have to really understand some of the different issues before I want to relay them. But it's to regards to payment. Payment drives practice in this community, and there was TDAPA is a program for Medicare that looks at innovation, and it allows a market to come to the community with a amount. It's a little bit more complicated than that, but I know you guys are working on it, but it's just, is it a big focus? Because payment drives what we get. We can have the best technology in the world, and then it's not available to us. And I'm a little bit biased because I bleed a product called Critline. I worked for that product for 4 years under the inventor, and I would not dialyze without that Critline. And there was no reimbursement mechanism for a couple of dollars for the chamber. You're aware of this. And, it's still not utilized because it's not paid for. And I feel that is, I'm very grateful as somebody who's received Medicare, we're a very specialized illness, so they're learning in the kidney program. But I just want to know your thoughts on payment.
Yeah, no, payment does drive care in many ways, and we're seeing we want the payment to support innovation, as I've said. And I can't talk about the proposed rule, but I will say, because I do sit in the meetings and we get to present the policies to the administration, that it is really important to this administration, and there's lots of consideration being given to it. So you can rest assured on that. I don't know what the final policy will be, but I do know that it's not just like one of those minor issues that no one's talking about.
And,
So,
I think it's important for everybody to know that, because we all have to chime in. And then my follow-up question is, and I did put this in my comments or since comments, but when we talk about incentivizing, especially when we want to move people to be on home dialysis, right? I'm like, is there some way to incentivize the patient? Like, is there some way, when we're doing our own treatment, can we get a reduction in our payment? You talk about respite care through Medicaid and Medi-Cal, but if you're on home dialysis, is there some way to get respite care in? So when I was on home dialysis for 9 years, and luckily I had somebody that could help me if I didn't feel well, but some patients may not, and then they go back in the clinic because they can't do it, and they never go back home. So has the administration given any thought on how to incentivize the patient to take on more of their care or recognize their effort?
So thanks for that question. And I think you said you put that in your comment, and I hope you did.
I did. It's all
Okay,
over
great.
the place. I've been doing that for a while.
Good. Okay, good. Because it is important, and we have to respond, look at those comments. But there are, in a fee-for-service environment, it is a little more difficult due to laws, that kind of thing. But there are opportunities, I would say, that might be available through the Medicare Advantage program, as well as some of the models that the Innovation Center is working on. And so as they hear those thoughts from patients, a couple models where they have looked at that with value-based incentives, but specifically for what you're talking about, I think those comments will be very important.
Thank you. Yeah, I just believe that it's so important because, and I'd like to give this example because we work with a lot of patients, and let's say there was a $300 to $500 incentive a month, for doing your own dialysis. And I lived alone. I was on PD, and I couldn't rotate. I couldn't open boxes. I mean, I'm only 4'10". I like to tell people I'm taller than I look, but I had sometimes trouble hanging bags when I was tired or something.
Mhm.
And, as a patient, you already feel sometimes you're a burden. I know I did. Like, I don't want to ask for any more help. I'm tired of asking for help. So if I had the resources to maybe say, hey, I want to buy you dinner or lunch or do something. So, if I have limited resources, but I know that, a little bit amount of money makes a huge difference to people. And not that I'm feeling that people should always be incentivized for taking care of themselves, but there is money in the bundle to pay for staff.
Mhm.
Staff for dialysis. And when you take on your own staff, it should be recognized by providers and to the patient. So that's my comment. I have a lot more, but I'll leave them to the next proposed rule. You'll be able to read them. And it's interesting. The more you learn in this field, the less you know. I mean, I'm like, oh my God, I didn't know that. Oh my God, I didn't know that. And so it really is complicated. So thank you so much for weaving through all those difficult policies. And we just posted an incredible podcast on emergency, and we'll put it in the chat.
Right.
But I really commend the kidney community. when there's a disaster going on, I want them around because they know how
Mm-hmm.
to go in and respond. I'm like,
Mm-hmm.
it's amazing. They're very organized. And so we've
Yes.
made a lot of progress in this community. And I
Mm-hmm.
appreciate your dedication. You've been doing this a long time, and we appreciate your effort, Jean. So
Great.
thank you. And I look forward to seeing you soon.
Okay. Thank you so much. Bye
Have a
bye.
great day.
You too.
And a shout out to our corporate mission partners for making this happen.